Thank you everybody for coming. I appreciate you guys taking time to spend some time here to learn a little bit more about hip and knee replacements. My goal here tonight is to make sure that everyone's questions or concerns that they have about joint replacement surgery gets addressed. I have a PowerPoint slide prepared to go over the basics of joint replacement surgery. We'll have some time at the end for some Q&A, so any questions you guys have, happy to answer any and all questions you guys have afterwards. But today we'll just go over a little bit about what hip and knee arthritis is. We'll talk a little bit about joint replacements and then some of the modern advancements that we have nowadays and technology that we have now to make hip and knee replacements much, much better, especially than we had in the last couple of years. So without further ado, I'll get started. So obviously, what is arthritis? So arthritis is when the joint changes for whatever reason. Anytime in medicine, if you hear the word itis, think inflammation. And inflammation comes in many terms. It's pain, swelling, change in temperature. But arthritis is specifically inflammation at the joint level. And there's multiple types of arthritis. There's osteoarthritis, there's rheumatoid arthritis, there's post-traumatic arthritis, and we'll touch a little bit about some of those differences. But it changes the normal mechanics of the joint, and that's what causes issues with pain, with mobility, and oftentimes it changes the normal anatomy of the joint. So like I had mentioned, there's 4 different types of arthritis. There's the typical and the classic one, which many of you probably have heard about, which is called osteoarthritis. And what that is wear and tear, mechanical wear and tear over time of the articular cartilage that lines the ends of your bones. If you ever think of that rubber ends of the chicken bones you guys have probably seen before, that's what cartilage is, and it's very similar to what our joints look like on the inside. So osteoarthritis is the mechanical wear and tear over time of that articular cartilage. Autoimmune arthritis, oftentimes associated with rheumatoid arthritis, is more of an autoimmune inflammatory process that causes the tissues around the joints to become inflamed. Over time, that inflammatory process starts to erode the articular surface over time. It's a little bit of a different pathology than osteoarthritis, but it's treated very, very similarly. Post-traumatic arthritis is exactly how it sounds. Any type of injury or a fracture that you may have had around a joint over time causes that articular surface to wear away. And then there's infectious arthritis, or what we call septic arthritis. That's a little bit of a more rare type of arthritis that we see from time to time, but the infection, it starts to eat away at the articular cartilage, leading to arthritis at the joint level. So why would someone need a joint replacement? How do we go about treating all these various stages of arthritis? Well, oftentimes we try to start non-surgically first, and I'm a big believer that majority of arthritis can be treated without ever making a skin incision or start doing surgery. Oftentimes we try to treat these with anti-inflammatory medications, simple things like Tylenol, Aleve, Advil, Motrin, physical therapy and exercise. There's a common myth that people think that exercise makes your arthritis worse, and that has not really been true and proven in the literature. In fact, exercise is chondroprotective, meaning that it actually protects the longevity of the joint level. It makes the muscles around the joint stronger and helps keep your joints healthy and strong. So exercise, weight loss is a very big thing too. The more weight you carry, the more it stresses the joints. So oftentimes, for every 5 to 10 pounds you lose, it takes about 5 times pressure off of the joints. And then we also do injections. So there's different types of injections. You probably have heard of cortisone injections, the chicken shot or the gel injections. Those are ways that we also try to help manage the symptoms of the arthritis before needing surgery. But at some point, those aren't as effective. And it starts to become more and more painful, starts to affect your everyday activities and everyday mobility. And that's when we start talking about joint replacement surgery. So when someone has irreversible damage to the joint and the articular cartilage has worn away, and they have daily pain, it affects their everyday activities, and it has failed all those conservative measures that we start, that's when we start having that conversation about hip or knee replacement surgery. And I have this bold and underlined at the bottom, and I think this to me, as an orthopedic surgeon who specializes in hip and knee replacements, this is probably the most important factor when I'm considering joint replacement surgery in patients. Obviously, I want to make sure you've done conservative management, you've tried non-operative management for extended periods of time. But if you've been trying those options and it's affecting your daily quality of life and the things that you enjoy doing are becoming more and more difficult as a result of the pain in your joints, that's when joint replacement surgery can be effective. People come in and they say, I can't pick up my grandson, I can't walk with my spouse, I can't play golf. Those are activities that no matter what age you should be able to enjoy doing. And I think when that starts to become what's affecting your quality of life, that's where I recommend talking about hip or knee replacement. So we'll go into a little bit about what hip and knee anatomy, about what we're talking about specifically. I'll try to keep this below a med school level. So I try to keep it as simple as I can to kind of have you guys understand what we're talking about with the knee joint and the hip joint. So the knee is, people think of it as a hinge joint that you can just bend and straighten it. And it's a little more complex than that. It has 3 different articulations. It has an inside, what we call the medial side. There's the outside, which we call the lateral side, and then there's underneath the kneecap, what we call the patellofemoral joint. All 3 articulations have very different mechanics. In addition to being a knee that bends and straightens, your knee also has a rotational component to it. It also has a translational component to it. And those are why those certain activities like going down stairs or walking long distances or even just bending down is what causes stress at that joint, and that's what causes pain from the arthritis. Your knee is inherently stable through a very complex, robust ligaments that surround the knee. You have your inside ligament called the MCL, your outside ligament called the LCL, your ACL, which I'm sure a lot of sports fans have heard about over and over, that's on the inside, and you have your PCL. And you also have menisci on the inside and the outside, and I'm sure many of you probably have heard of people that have had meniscus surgery done or meniscus injuries. Those kind of act as shock absorbers in the knee, and they also help give some inherent stability to the knee as well. All of these dynamic stabilizers play an important role, and as the knee becomes more worn out and more arthritic, the mechanics change, and that's what stresses a lot of these ligaments more, and that also contributes to the pain and the symptoms that people have with knee arthritis. The hip's a little bit more of a simpler joint, I would say. We always talk about it being a ball and socket joint, and it is very much like a ball and socket joint. The inherent stability from the hip comes from a lot of the muscles that surround the hip. You have what we call your abductors, which is the muscles on the side of your hip. Your butt muscles, called your glutes, those also give you inherent stability. And there's ligaments and a capsule that surround it. The hip joint composes 2 different bones. It's your femur or your thigh bone and your pelvis, which is basically where people feel on their hip bone. And the acetabulum, which is the socket, articulates with the femoral head, which is the ball. When we talk about arthritis, this picture I think kind of helps really display or depict what the process over time happens at the articular surface. Usually it starts with a little bit of some cartilage fraying, some fissuring. Think of it like cracks in the sidewalk. And over time, as you continue to walk and progress and put stress on those knees, those cracks or fissures begin to get bigger and bigger to the point where the underlying bone that's underneath that articular surface, underneath that cartilage, starts to rub up against the bone of the other joint. And you start getting bone spurs, what we call osteophytes, which is just a sign of how advanced the arthritis is. The menisci, those shock absorbers, will start to tear as the stress in the knee increases. The fluid changes in the knee, that's what gives you that stiffness. And then sometimes if the arthritis is super progressive, it actually gives you deformity. Sometimes we talk about it being a bowed knee or a knock knee. With the hip, it's a little bit more straightforward. Again, you lose that articular cartilage that caps the ends of the bones. As that arthritis and as that cartilage continues to wear away, you get those surrounding bone spurs. The labrum, which is very similar to the meniscus in terms of its makeup, begins to become more stiff and may or may not tear. You get impingement. And I have these 2 things here at the bottom, dysplasia and AVN. Probably one of the most common reasons for hip replacement surgery in this country is osteoarthritis, that wear and tear arthritis. But some people are born with what we call hip dysplasia. And what that is from when you were born and during development, the socket, the acetabulum, doesn't develop normally. And as a result, that changes the normal mechanics of the hip and over time leads to arthritis down the line. AVN, I don't know if anyone's ever heard of AVN before, but that's called avascular necrosis. That's a process that is the blood supply to the femoral head, to the ball side of the hip joint, dies. And over time, that articular surface dies as well, and that leads to erosion, arthritis, and eventually is one of the most common reasons for hip replacement in patients under the age of 50. So I'm going to try to not keep this too complex. I want to keep it straightforward and simple for everybody in the room to understand. But one of the big advancements that we've now had in knee replacement surgery specifically is our understanding of the knee joint is much better than it was 10 to 15 years ago. Traditionally, and I'll talk about this a little later on, but traditionally knee replacements for the last 10 to 15 years have thought about trying to make the knee straight. You're basically trying to take everyone's arthritis, despite how different it may be, and make them all the same, a cookie cutter approach to a knee replacement. And I think that works in most people, 70 to 75% of the population. But we've always found that there's this 15 to 20% of patients after knee replacement who aren't quite as happy with their knees. And we're starting to understand it's because you're trying to fit a square peg in a round hole. Everybody's knees are a little bit different. And if you try to force everybody to have the same knee replacement afterwards, some people are going to like it and some people aren't. And now we become more aware of that, and I think our approach to knee replacement has changed. I'm obviously a product of the newer generation with knee replacements, and I've kind of now grown up with this idea of what we call kinematic alignment, or what's being termed as functional alignment, where we're not trying to put everyone's knee exactly the same. Everyone's arthritis is different, and we're trying to account for that to give them the best outcomes that they can. So first things first, let's start with what is a knee replacement. Well, a knee replacement should really be called a knee resurfacing. We're not necessarily cutting out your whole knee and replacing it with these big clunky pieces of metal. We're really just resurfacing the ends of the bone where that cartilage has worn away, and we're capping the end of those bones with metal and plastic. You can see here on the thigh bone here, we cap it with a metal piece here, a metal piece on the top of the shin bone, with this plastic insert that goes in between, and that allows you to bend and straighten without the pain or stiffness. Now, there's two types of knee replacements. There's a total knee replacement, where we replace all those articulations of the knee, the inside, the outside, and underneath the kneecap. But some people could be candidates for what we call partial knee replacement, which is where we just replace the inside or the outside or just underneath the kneecap. It just depends on where that arthritis is isolated to. So the traditional approach to knee replacements for the last however many years, 30, 40 years, has been to try to make the knee what we call mechanical, make it straight. Despite how deformed or despite how advanced the arthritis is, we're just trying to make everyone's knee the same, a cookie cutter approach to knee replacements. And like I said, for 80% of people, that might be okay, but we've always had this crux in joint replacement surgery about how do we make that 20% of patients who are unhappy with their knee, how do we make them better? And we started to dig into alignment, and not everybody's knee is exactly the same. My knee is different than your knee, and your arthritis is different. And that difference is what accounts for some people not being as happy. You're trying to force their knee to be like the average knee replacement, and not everyone can tolerate that. And so typically we try to make everybody straight or mechanical. You see the straight line going down, and you're trying to make all the cuts flat and even and parallel to each other. And like I said, I think some patients don't appreciate that, and it causes them continued pain and discomfort. Now, probably within the last 5 to 10 years, we've come out with what we call this kinematic approach, or functional alignment to total knees now, where we try to respect and better understand everyone's difference in their knee anatomy and their knee alignment. And we're basically trying to put the knee exactly where it should be relative to your alignment. And for some people, that may mean having them a little bit more bowed. Some people, they might be a little bit more knocked, and some people might be a little bit more straight. It all depends on your anatomy and your deformity. So we realized that to try to correct everyone's deformity to regression to the mean, to make everybody the same, doesn't really work in everybody. And now we're becoming more skilled with the advent of technology specifically and robotics, which I'll get to in a little bit. Robotics allows us to plan for the surgery before we make any cuts and make sure we're putting the knee specific to your anatomy. So how does robotic knee replacement work? So I think robotic surgery is very different across different medical specialties. General surgery, OBGYN, their robotic surgery is very different how we do it in joint replacement. So this picture up in the top right-hand corner is actually what the robot looks like. It's about this tall and it's about this wide. And it's a robotic arm, and attached to that arm is a saw that I am still controlling as a surgeon. So people often think, I press a button, I walk away, I grab a cup of coffee, and I let the robot do the whole thing. I wish it were that easy, but You still need to have surgical technique and surgical skill to still put the knee specific to where you want to put it. So the arm of the robot is a tool, an extension of my toolbox to allow me to put the knee specific to your anatomy. There's different brand names out there. In our network here at Lehigh Valley, we actually have 2 different robotic systems. We have what we call the Mako robot and then the Velis robot. Just different brand names, but still do a very good job of putting the knee specifically and accurately to where we want to put it. And like I alluded to before we make any cuts, before we make any skin incision, we're able to plan for how that knee is going to be placed specific to your anatomy. We have these 3D planning options where we can actually plan how we want to position the knee relative to your anatomy, and it allows us to precisely hit that target consistently. It allows us to get better balance too. A lot of people have had issues with knee replacements over time coming up with what we call instability, where the ligaments that we had talked about earlier become out of balance, and that causes pain after knee replacements too. With the advent of the robot, we're able to get our balances pretty equal and within a 0.5 millimeter or so of balancing. That's pretty precise. Traditionally, without robotics, people were just kind of using their hands to kind of feel how the knee felt during surgery and after they had put the knee replacement in. And that's pretty good. I mean, it's still some human error in this. And I think now with the robot, we kind of take out some of that human error to get it more and more precise. So the question is this done prior to surgery or during the time of surgery? So it's actually done before the surgery. We actually have you get x-rays like we do normally. But some of these systems involve you doing a CAT scan. And the CAT scan is what gives us that 3-dimensional anatomy. X-rays are more 2D, but CAT scans are more 3-dimensional, and it gives us more and more information to plan for putting that knee specifically where we want to. The plan is made a few weeks before the surgery. And then during the surgery, we refine that plan as we're looking at your knee in real time. So we talked about that. So you get the planning done, and then during the surgery, what we do is we map your knee. So everybody's knee is different, and the way we account for that is by using sensors and devices to help map your knee anatomy to register to the robot during the time of surgery, during the operation. And so we incorporate that with our preoperative planning to make the precise cuts and put the knee specifically where we want to. And this picture on here is kind of showing you how the setup is in the operating room. So again, I'm still controlling the saw, I'm still controlling the robot. This is a picture of what the planning looks like on the top, and we're using that plan to guide us during surgery to precisely put the knee where we want to. And this is just a screen showing what that planning will look like, and we can plan how much or how little we want to resect, how we want to position the parts in the knee in 3-dimensional space. And it also gives us the ability to balance the knee throughout the entire arc of motion, so we know when we leave the operating room that your knee is as balanced as it could be. And then after that, once we make those cuts, then the knee replacement's implanted like normal. The literature on this is actually pretty good. I won't go through and bore you guys with details. I didn't like reading research when I was in medical school, so I'll try to save you guys the boring details. But what I will tell you is there's plenty of literature coming out in the last few years that has shown that that robotic-assisted total knee replacements have excellent outcomes. I would think that I think things that have made a big difference in my clinic personally, I think reduced operating time, I think a little bit quicker recovery, a little less blood loss, but more importantly, it's the precision that knowing that the knee was balanced and the range of motion is maximized throughout the arc of motion with the robot. The cuts, like we talked about, will give you within a 0.5 millimeter of accuracy. That's pretty precise, and that's better than the human eye or the human hand can reproduce. And I have this picture here to kind of replicate that. Obviously, you want the best outcome for your surgery, and we as surgeons strive for that precision. And there's accuracy and there's precision. You can be a very accurate surgeon and your knee replacements can come out the same every time, but if you're not precise, and that's what this picture is showing here too, I know there's a lot of people that hunt or who are people who are sharpshooters, but the accuracy and precision thing is important to understand. You could be doing a very good job, but if you're outside that target where you want to hit, that's where the robot comes in and makes that accurate and precise consistently every time. And that's what we're trying to strive for as surgeons. And that's what you guys deserve as patients, that your knees should come out being accurate and precise. But ultimately, and this is where I always tell patients who are coming in requesting robotic-assisted knee replacement surgery, ultimately the robot is a tool. No matter whatever surgeon is using the robot, they should understand that if you blindly follow what the robot tells you to do, if anyone's ever seen Terminator, you know that those robots are going to take over and you're not going to want to follow them what they're telling you to do. So it's a tool, and I equate it to like GPS in your cars. I think everyone now has GPS, and it's been great, and it's, 30 years ago we didn't have that, and you were still able to get from point A to point B without needing a GPS. And people were able to do knee replacements for 30 years without needing robotics too. But now you're able to get from point A to point B accurately, hit it, and you're hitting a destination on time, and you know that time before you even start. It's the same idea with the robot. It's going to tell you exactly where you want to go from point A to point B, and it's going to guide you in that direction. But the ultimately as a surgeon, you're still responsible, and you still want to make sure that what the robot's telling you makes sense. Nobody here would follow the GPS if it said turn right into a lake, right? I mean, if they told you that, you would definitely not follow that. It's the same idea with the robot. If the robot was telling me something that I know is not right or not accurate, then I would reassess, reset, and make sure not to blindly follow what it's telling me. So it's just a tool, an extension of my toolbox to hit a precise target every single time. So a little bit of how it reduces pain. I think I'll touch base a little bit on this, but it's a little less instrumentation needed. You don't have to drill as much in and around the knee to put these cut guides on anymore. Now we can just map everything out without needing any cut blocks, no drilling or pinning anything down to your bone, and it's just the saw cut making those cuts for us. The soft tissue balancing, one thing that's nice about the robot and what mechanical alignment used to do was, if you're trying to make everyone's knees straight and force everybody's knees straight, you have to cut some of the ligaments or soft tissues or the tendons around the knee to get it to go straighter. That causes pain. With the robot and with this idea of kinematic alignment and putting the knee specific to your anatomy, you don't necessarily need to do those releases anymore, so it's less pain from the cutting of that soft tissue. The balancing is more accurate. I think that's one thing that helps too. A balanced knee feels good. A non-balanced knee hurts. And then, like I said, it feels more like your own knee, and we can, what we call the forgotten joint score, which is you want to forget that you had your joint replaced. That's what we're trying to strive for. Now, it's still a mechanical knee, right? It's never going to feel like it did when you're in your teens or 20s. But the idea of joint replacement surgery is to take away your pain, get your mobility back, and as best we can, make you forget that you had that knee replacement done. And the robot does help with kind of giving you that forgotten joint score, forgotten knee score. And then we also have multimodal approaches to pain now. We've gotten much, much better at understanding how to manage pain after knee replacement. And a lot of that's a multimodal pharmacologic approach to pain management afterwards. The anesthesia's gotten better. We do a lot of these under spinal. That does a lot, not only helping with reducing pain, but also reducing blood loss. We do regional blocks where we block some of the nerves around the knee to help mitigate pain. It also helps mitigate the amount of narcotic pain medications you use afterwards. Our tourniquet time is a little bit less. That helps as well. During knee replacement, they probably don't oftentimes tell people this. I try to tell my patients this all the time. We do a tourniquet, and the tourniquet's on your thigh for about an hour or so, and so that causes some pain as well. I think now with the advent of the robotics now and being better at our surgical technique, we've cut down significantly at our tourniquet time, which helps reduce some of the thigh pain after surgery. During surgery, I inject around the knee as well. I inject a numbing medicine that lasts for about 48 to 72 hours, and that helps increase pain or reduce pain after surgery as well. And getting up and moving quickly. We get people up and moving very quickly after knee replacement. Traditionally, people used to be in the hospital for 3 to 5 days after joint replacement surgery. You wouldn't start physical therapy for almost 2 weeks. That's completely shifted now, and we understand that one of the best things you can do after joint replacement surgery is to get up and move, and we get you into physical therapy within a day or so of surgery, and some people we send patients home same day after surgery. So we've come a long way over the last couple years now about increasing our mobility and our therapy afterwards. I'll touch a little bit about partial knee replacements. Now, patients who are candidates for it mainly have to have arthritis on the inside area of the knee. Once you have arthritis in other areas of the knee, a partial knee replacement is not going to serve you very well. But the advantage is you keep the remainder of your knee. I mean, you can see here, this white is all that they replace during a partial knee replacement, versus here, what a total knee replacement replaces everything. So it feels a little bit more natural. The recovery is a little bit quicker. It's a little bit less surgery, and your ligaments still remain intact. So that helps people recover a little bit better and makes the knee feel a little bit more natural, a little more kinematic. And the robot also helps us with that too. So we have robotic-assisted total knee replacements, and we have robotic-assisted partial knee replacements. And the process is very similar. The planning is similar. But opposed to doing the entire knee, we just replace the inner side that's arthritic. I touched a little bit on this, but I'll reiterate again. Our physical therapy department in our hospital and our network here at Lehigh Valley do an excellent job. I probably send 90 to 95% of my patients to our physical therapy offices in our system. We have offices throughout the valley, so it's very convenient for patients to get to a physical therapy office after their surgery, and we try to coordinate their care pretty quickly. We get you in within 2 to 3 days after your surgery. We get you started in physical therapy. Oftentimes seeing the same therapist or two helps too, to get consistency. And that's what's nice about keeping it in our network and sending our patients to our Lehigh Valley affiliated rehab facilities, is that they're able to have that consistency with their same physical therapist every time they go. Any questions about knee replacement surgery before I move on to hips? So not everybody in the network does robotic-assisted joint replacement surgery. We have a good number of surgeons that do. If you go on our websites, and you can always Google the robotic-assisted knee replacement surgery as well, but on our websites it'll say, so-and-so is certified in robotic-assisted joint replacement. So not everybody is, but I always encourage you to always ask your surgeon too. Sometimes they may have gotten trained on it and now they're starting to use it. So always ask your surgeons if they're robotic-assisted surgery, if that's what they're doing. So actually, during a total knee replacement, we take the ACL. We cut the ACL out, and the inherent stability comes from that knee replacement. In a partial knee replacement, you keep the ACL. And one of the indications, one of the requirements to have a partial knee replacement is to have your ACL intact. So the plastic insert on the inside has inherent constraint and stability that kind of contours to the actual femur, to the thigh bone. Your ACL is to prevent anterior translation, right? So the mechanics and the way that the plastic insert is designed, it has stability to prevent that from sliding forward. So it's actually the plastic that replaces your ACL. We also cut out your meniscus as well, and that is replaced by that plastic insert that goes in between. I try to do spinal on almost everybody that I can. There are some indications that you can't do a spinal. Certain blood thinners, if you've been taking, if you've had previous spine fusions or hardware, it's tough to get the spinal into the back. But I try to do it on almost everybody. It does help a lot with pain. It helps a lot with blood loss. Patients are up and walking a little bit sooner afterwards as the block tends to wear off. So that's the spinal is what goes into your back. The blocks are what we do peripherally, and we inject medication that numbs the nerves around the knee for a few hours to help as well. I check my patients right after post-op, and I would say 99% of them are still numb from the block. So it does its job for the first 24 to 48 hours. So I use glue. I think it gives a little bit cosmetically better scar. I think it does a little bit better job too of sealing the wound. There's also nothing to take out in the office. I don't know how many people here have had staples or stitches removed or no. It hurts. And as someone who takes them out in the office, I can tell it hurts because I have people screaming and yelling that it hurts. So I use the glue for a couple reasons. Number one, I think it gives a more cosmetic closure. Number two, like I said, there's nothing to take out in the office. It's very easy. You just take the bandage off and that's it. And then the third thing is with drainage. There's very, very little drainage, and there's studies out there that show that there's very, very little drainage with the glue closure versus staples. A lot of it is surgeon preference. I think a lot of surgeons have been using staples for years, and it does a good job. Some of it's for speed purposes. It's a little bit quicker to close with staples than it is with the glue. It takes a little bit more time to get that closure with the glue. But a lot of it's just surgeon preference and what surgeons have done for years. I think nowadays more and more people are migrating towards the glue now. They understand that it gives a little bit better closure, a little bit tighter seal, and prevents some of that drainage from happening afterwards. So I'm doing glue for all my patients, yeah. I always tell this to my patients who always ask, am I too old or too young for a knee replacement? I've done a joint replacement in patients as young as 18 and as old as 95. I just did a gentleman who was 93 2 weeks ago. Age is just a number. And in 2024, I think people's health people are living much, much longer. And as a result, they're more active than they were years ago. There are a lot of 80-year-olds that I see that are much more active than some of my 30 and 40-year-olds. So age does play a role, but it's your functional age. How active are you? How healthy are you at baseline? What's your mobility like? Now, if you're someone who has been using a walker or a cane for however many years, yeah, your recovery afterwards might be a little bit longer than somebody who maybe is a little bit more active and doesn't use a cane at all. So I think age isn't so much the chronologic age that factors into it. I think it's more your functional age and what your mobility and your function is at baseline that factors into it. it can't help break up adhesions. It's not designed that way. It's designed to perform a total knee replacement. And there's starting to become now more and more work on robotics for revision knee replacements where you have to have a redo. So that's kind of coming on the market now on the horizon as the next kind of generation of robotic-assisted surgeries to help those patients that didn't have a good outcome the first go-around. How can we use robotics to help get them a better outcome the second go-around for a revision? The technology is still in its infancy stage, but we're trying to tackle that problem. Unfortunately, at the moment, there's really no good kind of robotic plan or robotic solution to a painful knee replacement afterwards. Yeah, and like I said, there's that 20% of people that do, and I think because our understanding has gotten much better, we've actually been able to lower that number much, much better, and the advent of the robot has helped. It doesn't change that much. The only added is, now, I don't know if anyone here has had a robotic knee replacement done. So the only thing that's added to it is we put these little arrays, or these little sensors into your bone, and that's what allows the robot to read your knee in real time during the surgery. So there's a small little stab incision you get down at the bottom, near the middle part of your shin bone. That's the only difference between the regular knee replacements robotics is with the incisions. So it's about 8 to 12 weeks, depending on your functional mobilities at baseline. You're up and moving right away. You're up and walking with physical therapy, doing some steps within those first couple of days. The most intense period is probably that first 6 weeks or so with physical therapy. That's when you're really working through a lot of the swelling, the stiffness, the scar. A stiff knee hurts, and the knee wants to stiffen up because of that surgery. And so the first 4 to 6 weeks, you're working aggressively with physical therapy and doing exercises on your own to work on breaking up that scar tissue from forming, bringing down the swelling. The other 6 weeks or so is working on your strength, right? So bringing back your quad, your hip muscles. That stuff takes a little bit more time after surgery. So on average, I'd say most people are feeling about 80% better at about 6 weeks and about 90% better around 10 to 12 weeks. I'll move on to hip replacement surgery next, since we're about the halfway point here. So we talked a little bit how the hip works, right? The mechanics of the hip is more of a ball and socket. It's a little bit more inherent stability based on the muscles and the bony anatomy of the hip. And we talked about the ball being the femoral head and the socket being the acetabulum. So one of the more, I would say, newer advanced, it's been around for a long time, but it's becoming more and more popular in the last 5 to 10 years, is the anterior approach to hip replacements. Traditionally, hip replacements used to be done from what we call a posterior approach, where you had an incision along the backside. We cut through the muscles of your butt to get down into the hip, and then do the hip replacement, and then that's pretty much the end of it. Patients do pretty well. Hip replacements have done well for generations, for the last 30, 40 years since we've been doing them, with that traditional approach. I specialize in anterior-based approach for total hip replacements, and what that is it's an incision, instead of being along the back, along your buttock area, it's along the front. And the benefit is there's no muscles to cut. We don't cut through the big butt muscles in the back. We kind of just move the muscles out to the side. Naturally, your body has this plane in between some of the muscles that get you right down into the hip. So I just find that normal native plane that you have, move the muscles out to the side to get down into the hip. So we don't cut any muscles, there's no detaching of any muscles, and it helps a little bit with the recovery after surgery, particularly in that first 4 to 6 weeks. And I will say, a lot of my partners, a lot of people in our system still do the traditional approach from the back, and they do great. A well-done hip is a well-done hip, whether you go from the front, back, or the side. And I tell my own patients that, even though I do an anterior-based approach. A well-done hip at 3 months, at 1 year, whether you do it from the front, back, or the side, does well. But I think in those first 4 to 6 weeks, the recovery seems to be a little bit quicker from the anterior-based approach, just because there's no cutting of those muscles. So I always tell people that, that a little bit quicker recovery, but ultimately what you want to do is what's best in your surgeon's hands. In my hands, I feel very confident and comfortable doing an anterior-based approach going from the front. Some surgeons are confident and comfortable going from the back, and that's okay too. You want what's best and what's most comfortable in your surgeon's hands. But like I said, I think those first couple weeks without cutting those muscles, as you do from the posterior approach, patients tend to do a little bit better from the anterior-based approach. Again, I think it's no matter how you get there, there's multiple ways to skin a cat. And I think as long as you do a good job doing the hip replacement, the approach should be what's most comfortable with your surgeon. So if your surgeon was comfortable doing it from the side, he did a good job, clearly, that's great. And I'm not trying to bash the other approaches that are out there. For me, I do an anterior-based approach. It's a little bit newer approach. Not too many people may know about it. And so I think kind of making patients aware. The most important thing that you guys are here today to do is to become informed patients. And that's your right as patients. You should be informed. You should know when you go see your surgeon, you go see your doctor, you shouldn't have your doctor just tell you things and you take it as God. You should know your own the literature and learn some stuff on your own, and you should come informed and ask the right questions to your surgeons. And that's kind of the point of tonight really is, even if you guys don't see me in the office for your hips or your knees, at least I'm giving you guys some information that you can take to your surgeons and ask them questions about robotic-assisted knee replacement or anterior-based heel hip replacement, just so you guys are informed and know what other options are out there. So the posterior approach, like I talked about, is kind of traditionally from the back along the buttock area, we cut the butt muscles to get down to the hip. But the anterior-based approach is kind of right on the front area, just around the side of your hip in the front. You can see here, this is the natural plane that's in your hip to get down there, and we just move those muscles aside and perform the hip replacement just like you do from every other approach. So the actual surgery doesn't change as far as putting the components in, but the muscle-sparing approach I think helps a lot. And I think the literature on that is pretty convincing, particularly in those first couple of weeks when we compare patients that had their surgery done from the front and from the back and from the side. Patients tend to do a little bit quicker, a little bit better in those first 6 weeks from the anterior-based approach, again, because there's no muscles to cut from the front. The other thing that helps too is we're able to optimize hip mechanics and hip stability. And you can do that from any approach. It's nothing that the anterior-based approach provides more than the posterior-based approach. But what does help is the ability to use X-ray. And I use technology during my hip replacements for a couple reasons. Number one, it allows me to hit that precise target. So I know that I'm optimizing the stability and the mechanics of your hip. And the way we do that oftentimes is to lengthen the leg. People always talk about, or probably heard, that there's always a risk of your legs maybe being a little bit longer after hip replacement surgery. Now, we're not making you, one leg tall, one leg short, and you're kind of walking around like this. It's not like that at all. But usually within a few millimeters. And I think with technology now, and with the anterior-based approach specifically, I'm able to get those within millimeters. I'm talking 2 millimeters or less. In addition, it allows me to put the components exactly where I want to put it, and I have objective numbers to use. One of the things that people talk about, one of the problems after hip replacement is dislocations. I don't know if anyone's ever heard of anybody that a hip that popped out, but that's a risk that can happen after a hip replacement. The way we mitigate that risk from happening is putting the components in the appropriate position that maximize stability, prevent issues with dislocating, but also optimizing that tension of the muscles. The muscles, if you remember before, we talked about how the normal hip anatomy has muscles that inherently give it stability. And we're trying to put tension on those muscles to prevent issues with dislocations afterwards. And I think part of the advent of technology, and especially in the anterior-based approach, is we can use X-ray. And I can take a picture of your hip during the surgery with the trial components, not the real parts. I don't buy anything just yet, but I'm putting the trial parts in and say, is that hip optimized? Is their length optimized? Are the parts positioned where I want to? And this is what that looks like for me in the operating room. I'm making all these measurements, I'm measuring everything out, and knowing that it's precise and accurate to where I want to put it. But again, and this is the bottom line, and I want to make sure I reiterate that again. You ultimately want to do what's best and most comfortable in your surgeon's hands. We have great hip replacement surgeons here at Lehigh Valley that do a posterior-based approach, and patients do phenomenal. And that's what's most comfortable in that surgeon's hands. And so that's what you want to make sure that whatever's best in that surgeon's hands is the most important thing. Personally, for me, I think an anterior-based approach does a little bit better. There's no muscles to cut. You're up and moving a little bit quicker in those first 4 to 6 weeks. But like I said, at 3 months, at 1 year, a well-done hip is a well-done hip, whether it's done from the front, the back, or from the side. Again, we kind of talked about robotic assistance during hip replacement surgery, very similar to what we talked about with knee replacements, right? It's still me as a surgeon performing the surgery and doing the surgery as I always do, but it just gives me that added tool to be more precise and to hit a consistent target every time I leave the operating room, to know that I put the hip in the best position for that patient. Any questions from anybody? Yeah. Our technology has gotten so much better in the last 10 to 15 years that traditionally they used to last 10 years maybe. Now they're lasting 25 plus years. The biggest advent has been that plastic that I had talked about earlier. Traditionally, that plastic used to wear out after about 10 years or so. Now they're lasting 25, 30 years. It's what we call highly cross-linked polyethylene. That's become new in the last 10, 15 years or so. That highly cross-linked polyethylene, that's what the plastic is made of, has longer survivorship and less wear rates than it has before. So they're lasting much, much longer. Most people, if you had joint replacements done within the last 5 to 7 or 10 years or so, but definitely the last 5 years, the plastic that people have been putting in now are the ones that have been lasting much longer. I don't, and I wouldn't recommend it. It's a longer surgery, it's a longer recovery, it's a lot more blood loss and a lot more risk of complications with blood clots and bleeding. We don't typically do a hip and a knee at the same time. It's very rare, and there are very, very few instances where we would actually do we do 2 knees at the same time. That takes the right patient, a motivated patient with very minimal health comorbidities or risk factors that can tolerate a little bit longer surgery. So traditionally we try to stage them, do 1 joint at a time, about 3 months or so apart. And I think that does a little bit better because it allows you to recover from that 1 joint, and then you can rely on that when the other one gets replaced. It's hard if both knees get replaced or both hips get replaced at the same time. It's really hard to recover because both are painful and both are going through the same rehab at the same time. Patients that I usually do, I tell them I stage them 3 months apart. They get enough strength out of the one to rely on when we replace the other side. It takes a good clinician and a good doc to figure that out. Sciatica typically comes from nerves in the back, and sciatica can present itself as hip pain, and so x-rays help. So hip pain with no arthritis evident on x-rays or MRIs or any advanced imaging, typically then we can kind of discern that from coming from the back. A good exam, so clinically examining you in the office, getting a good history and figuring out what your symptoms are, also helps us discern between hip or back. And then the other thing we do sometimes is an injection for 2 reasons. One, it's therapeutic, it can help take away the pain, but for us as clinicians, it's actually it's a diagnostic tool. If we inject your hip and you still have that pain, that sciatica pain, well then we know it's not the hip. By the same token, if we inject the hip and it goes away, then we know that that hip pain was coming from the hip arthritis and not so much from the sciatica. It's very, very rare. And I'd say the literature, if I can remember correctly, is about less than 0.5% of patients are truly allergic or would reject a knee replacement, the metal that's in there. People that have a nickel allergy or a metal allergy, what we do is we test them, and we test them with a skin test with our allergy or our ENT partners to try to see if they have a true allergy to the metal. And if you do, we actually have nickel-free implants that we would implant with you to help so you don't get that reaction. So there's actually implants that are designed to not have the same amount of nickel that you have a reaction to prevent that from happening. So if that were the case, that's what we would do. We would use a nickel-free or an allergy-free implant to help with that. So an anterior-based approach doesn't have very much restrictions. The dislocation rate after an anterior-based approach and also from an approach from the side is very, very low. It's almost 0%. As far as activities that you can get back to doing, after about 8 to 12 weeks, most people are getting back to hiking, biking, walking, light jogging, golf, tennis, pickleball, swimming. Those are pretty much the activities that most people are getting back to doing. My younger patients I've done hip replacements on, they want to go back to playing basketball. One guy asked me to go back to playing rugby. I'm a little more cautious for those things, but I had one of my younger patients I did a hip replacement on. 6 weeks later, was playing basketball. So that's a a little bit of an outlier, but most people are back to doing those activities like I talked about with very little restrictions. A posterior-based approach, you do have some precautions after surgery for the first couple of weeks. And that's because the risk of dislocation is a little bit higher from the approach from the back. And particularly that's when you bring your leg up, and particularly up and out to the side like that, that's going to put that risk of dislocating. So they might do some precautions afterwards with a posterior-based approach, but for an anterior-based approach, and certainly from one from the side, there's no real restrictions afterwards as far as the dislocation rate. It depends on the surgeon. Some surgeons use it all the time. I use technology as much as I can. I think it's in 2024, I think technology it's become much more advanced, and it gives you that precision that you'd want. So I use it as much as I can. Some people use it in more complex cases. So if you have a really deformed hip or a really arthritic hip, it helps kind of with addressing that deformity. But it depends on the surgeon, and some people use it all the time, some people use it half the time, some people use it part of the time. Checking in with your surgeon or any joint replacement surgeon who can specialize in revisions. Checking in every 2 to 5 years is important. Oftentimes to get x-rays. Sometimes we can start to catch early signs of loosening on x-rays. So every 2 to 5 years, I always tell patients it's always good to get a checkup just to make sure things are holding up okay. If you start having pain that becomes, every once in a while you might get a couple of aches and pains in the hip, and that's okay. But when you start getting consistent pain, daily pain, getting worse, and it becomes more and more difficult to walk, that might be a sign that things are starting to wear out, and getting that looked at with an x-ray and further workup is important. Obviously, a well-balanced diet. I always tell people you want to make sure you're eating right. Putting fatty, unhealthy foods is going to change the mechanics and the chemistry of your knees and your hips. So well-balanced diet is good. Glucosamine chondroitin is a supplement you can buy over the counter. That's been shown to kind of help as well with keeping your joints healthy and strong. Actually, there's some good literature about turmeric. It's a good anti-inflammatory to take. So turmeric is not, as I tell patients, I'm never opposed to trying that as an option. Fish oil and all the vitamins and stuff like that are always good to do too. Good healthy, calcium and vitamin D intake to keep the bone strong as well. Whatever's the worst one, I guess, is kind of the easiest way to do it. It's a little bit easier to recover after hips. So I try to say get the hip done so you can recover better after the knee. It's hard to do the knee replacement rehab with a bad hip. So I try to get to the hip first and then do the knee second. It depends. Obviously, I'm one of the newer surgeons to the area, so I'm still trying to ramp up my practice. On a given week, somewhere around 6 or so. In a given year, Kim's in the back, so she might have my numbers. I'm not really sure how many in a year, but I should be somewhere around 150, 200 a year, somewhere around there, seems right. It's a procedure that we do in the office where under ultrasound, we're able to find and isolate the nerve that's causing the pain from the arthritis, and we inject a chemical or a compound in to block that nerve from sending the pain signal. It's effective to an extent. I only really reserve that for people who are either not candidates for or not interested at all at getting a knee replacement done to help manage the pain. The literature doesn't really show much effectiveness with the gel injections in the hip as much as it helps with the knees. We talked about how different the hip and the knee joints are. And so gel injections for the hip, we don't do. They're not as effective as they are on the knee. So the only injection options out there are the cortisone injections for the hip. And they're actually pretty effective. I do them myself in the office under ultrasound. To isolate the joint, we inject the cortisone directly into the hip joint. Depending on the severity of your arthritis, if it's severe arthritis, it might not help too much. But I've had patients that I've injected and I haven't seen them back for 8 to 12 months, and it lasts a long, long time. But unfortunately, there's no gel injection option for the hip as there is for the knee. Yes, they are. And same with knee replacement surgery too. We try to do our best to get you optimized. We actually have a bone health clinic in our Orthopedic Institute that we can help you go to beforehand, that we can work on getting your calcium and vitamin D levels and get your bone stronger in time for surgery or after surgery. But we have hip replacement surgery, especially hip risk of fracture afterwards is about, it's not 0%. It's a risk factor. Sometimes what we do is we will cement a knee replacement, or we will cement a hip replacement for those patients that have osteoporosis who are prone to fractures after joint replacement. And cement is It's almost like grout in a way. It's basically, it binds the bone and the metal implant together. It goes in between the metal and the bone, and it acts as a grout to help those patients who have weaker bone, to help the implant stick to the bone, I guess I would say, but helps it last longer and prevent issues like wear over time. So for patients who are osteoporosis, we do joint replacements for those patients, hip and knee replacements, but sometimes we may augment their implants with that cement that we can put around there to help with the fixation after surgery. Oftentimes before you leave the hospital, if you're going home same day, and most people, realistically, they go home the next day. They're not spending more than 24 hours. Part of the requirement to go home is you work with our physical therapist, walking up and down the hallway, 200 feet or so, and we actually have you do a couple steps as well. So I don't really limit people to doing stairs afterwards. I try to say as much as you can do as soon as you can. And maybe sometimes that's one at a time, holding onto a railing, taking your time to get up there. But yeah, that's where I tell people as quickly as you can to try to do steps. There's no restrictions from that standpoint. So as much as you can tolerate, really. For the cortisone injections, and I don't know if everybody's aware of this, but you should be. If you have a cortisone injection, the risk of infection is high if you do surgery within 3 months of that cortisone injection. Our goal is to try to mitigate as many complications as we can, and one of those risks is infection. Infection is a very common complication after joint replacement. It's a very devastating complication too. It has higher mortality rates than some cancers in our country, so it's a big deal. So we try to mitigate that risk by limiting how quickly we do a joint replacement after an injection. So the answer is 3 months. I operate out at Hecktown Oaks in Easton, so right where 33, right off of 33. We do a lot of joint replacements there. That's where the robot lives, actually. Me and my partner, it actually lives in a little pod in the corner of the operating room. Has its own little special spot too. It's actually kind of funny. But me and my partner, Dr. Brown, him and I are the ones that do a lot of robotic-assisted joint replacement surgery at Hecktown Oaks. So we do a lot of joint replacements there. Our therapy, our nursing staff, our OR team is very good with our joint replacement patients. So that's where I operate out of majority. I want to thank everybody for coming. I know, like Kim said, I really appreciate everyone's time. Thank you guys.